We're going to talk about healthcare reform, not just about single payer, it should be said. It seemed to me a good way to learn about the Affordable Care Act is actually to contrast it with the potential for a single payer approach. Just some disclosures. I think anyone that gives a talk on healthcare, I hope even your basic scientists tell you whether they have any connection to the pharmaceutical industry or otherwise. I don't believe I have any relevant financial relationships, but as you have heard, I am involved with this organization called Physicians for a National Health Program, but they have never given me any money. If anything, I have contributed money to them. So what are we going to do this evening? We're going to look first a little bit at the politics behind the Affordable Care Act. You all know that that's what other people have called Obamacare. I prefer not to use that term because it was really, I think, invented by the right wing to undermine it in some major ways. Then we will list the challenges facing the U.S. healthcare system and go one by one through each of those challenges, seeing how the ACA addresses them and how a single payer might address them. So, to start with, it's really fascinating now that we go back as much as 2008 and early 2009. Unbelievable. When I think about it. When President Obama was elected, he faced, I think, a kind of fateful choice. He didn't want to start from scratch. He was absolutely right. Build on existing healthcare programs. But he had a choice. One was to build on the private sector, namely private health insurance. The other was to build more on the public sector, Medicare, Medicaid, what have you. Which do you think he chose? Any answer? Yes?
Build on the private sector.
Predominantly building on the private sector. But if you had said that he also chose to expand Medicaid, there was a public sector component to it. But fundamentally, he wanted to build on the private sector. And he was following in an interesting historical tradition. Here's the first president that actually, when sitting in office, advocated a national health insurance program. Anyone recognize him? No. That's Harry Truman, okay? Did Harry Truman get his national health insurance program? No. So it was left up to this chap here, Lyndon Baines Johnson, when he finally, he came to the presidency because of the assassination of Kennedy, but then he was elected. And after he was elected, he proposed a program called the Medicare program. Essentially a program for people over 65. And you could argue in that day it was actually a single payer program for people over 65. And then along came this chap who you may actually recognize. Does anyone recognize him? Yes. Who is that?
Teddy Kennedy.
Teddy Kennedy. He wasn't a president, but he was sitting in the Senate. And he said, let's take that Medicare program and give it to everybody in the country. Did Kennedy get his, Medicare for All program? No. Why? Because this guy was sitting as president then. Anyone recognize him? That's Richard Nixon. And he said, oh no, we're not going to do that, but let's insist that every employer has to offer health insurance. But Nixon didn't get his employer mandate, so along comes Bill Clinton, and he adds to the employer mandate an individual mandate. And that was in 1993, 94, and here's the the language that was in the bill. Each eligible individual must enroll in an applicable health plan for the individual and must pay any premium required with respect to such enrollment. Whoa, that is a real individual mandate. Did Clinton get his individual mandate? No. So along comes Barack Obama, and he says, let's combine these two things, an employer mandate and an individual mandate, but in order to make this a little bit more acceptable, he came up with the idea of a public option. You can choose to enroll in a new or potentially an old public plan. And the original robust plan that he put forward in March of 2009 was open enrollment in the Medicare program for anyone who wants it. I don't like the Cornell, health plan. I could decide, in fact, to enroll in this new Medicare plan. It would have Medicare rates, so it would be very efficient. It wouldn't have to go out and negotiate with every doctor and every hospital. And it would be backed by government, so it wouldn't have to, in fact, put aside reserves the way a private insurance company has to do. And along comes Lewin and Associates, a consulting firm, interestingly owned by United Healthcare, one of the largest private insurers, and Lewin and Associates, which made some calculations and said that 119 million people would enroll in that new healthcare option, public option. That's interesting. How many uninsured people do you think we had in 2009 in the United States? Anyone have a guess? Yeah, that's about it. 48.9, some, 50 million roughly uninsured. So you mean there would have been a lot of people who had employment insurance like I did, who might, in fact, opt for this approach. You notice that this is not going to be, the public option is not a single payer, because in fact, you would maintain all the private insurers as well, so there would be some level of inefficiency here. And what happens? Well, the private insurance industry, the pharmaceutical industry freaks out. And in 1 year alone, they spent $1.2 billion on lobbying to try to defeat this public option. And this data comes from the Center for Public Integrity. This isn't my data, okay? And so what occurs is that by November of 2009, the House of Representatives passes a plan. It has a public option in it, but it's very restricted enrollment. You definitely have to be uninsured, okay? It is estimated by the Congressional Budget Office, because of some of the other restrictions in this, that only 6 million people would in fact enroll in this, and it would have to behave like a private insurance company, negotiate rates with every provider, and be self-sustaining. But even that was too much for the Senate. And I remember this vividly because the Senate passed its plan on December 24th, 2009. Can you imagine? Christmas Eve. And that plan, the Senate plan, had been designed by a staffer on the Finance Committee, Liz Fowler, and her role was as a former vice president of WellPoint Insurance, a private insurance company. No public option. Well, Obama was faced with an interesting problem. What usually happens when there's a different bill from the House from what is passed in the Senate? They create a conference committee and negotiate out the differences. But an election occurred in the state of Massachusetts in January of 2010. For Senator Kennedy's position, he had just died of a brain tumor. And who was elected? Scott Brown. Whoa, there's somebody that knows this history. And Scott Brown was a Republican, and Obama lost his 60 votes in the Senate. So what did he decide to do? Well, the Senate had passed a bill already. I don't have to reintroduce it into the Senate, he said. All I have to do is get the House to agree to the Senate bill. And that's what actually happened. And that's how we got the Affordable Care Act, which was signed March 23rd, 2010. Yes?
I've heard from time to time that Senator Joe Lieberman was also involved in killing the public option. Do you know anything about that?
Yes, I can tell you that he was certainly somebody who spoke out vigorously in opposition of the public option. I don't know much more than that, but I think you're absolutely correct. So what was the Affordable Care Act, or what is it? This is what it, it's pretty amazing. It's pretty complex. It was a bill, it's roughly 1,400, 1,500 pages. It has insurance reform and delivery system reform in it. And you can see, things like, Medicaid expansion, the creation of exchanges. Subsequently, they felt they really should be talking about marketplaces. That might be a more accurate word. Guaranteed issue, kids under 26 could be covered on their parents' policies. A whole bunch of other things, prevention benefits, prescription drug issues. And then delivery system reform, everything from ACOs and bundled payments to the creation of dual eligible programs, all the way down to things like federally qualified health centers. I'm not going to talk so much about this side of the equation. You're welcome to invite me back. But we'll talk mostly about the insurance side of this law. So what did we get? The ACA is fundamentally a mandate model of healthcare, a market-oriented way of providing health insurance. Everyone is required to have health insurance or pay a penalty. And you all know that started in 2014, so that the penalties were actually paid in 2015 if you didn't have insurance. And what were they? No, they were not $695 in 2014. It turns out they were $95. They are going to be $695 in 2016, this year, okay? And for families, it could be as high as $2,085. But there is also an employer mandate here. If you're an employer and you hire more than 50 employees and you do not offer health insurance, then you as the employer are going to have to pay the government $2,000 per employee per year. So there's a little bit of pressure on the employer to offer health insurance. And I argue that this was absolutely necessary for the survival of private health insurance. You'd have to force people to buy this product, frankly, because it's a very defective product, as we will see, okay? And indeed, that's what was happening. In 2009 alone, 6.3 million people stopped buying private health insurance. And okay, that was probably due a lot to the recession, 2007-8 recession. But if you go back a decade before that, there were 15 million fewer people in 2009 buying private health insurance than existed over that decade. And unless you forced people to buy this defective product, I argue they wouldn't do it. So then, of course, we had the Supreme Court challenges, right? The first of which was, can government mandate citizens to buy a private product like health insurance? Or is that violating their individual rights And the Supreme Court ruled 5-4, yes, government can do that. But at the same time, the Supreme Court said that the federal government can't mandate states to increase eligibility for Medicaid. That was another component of the law, right? And the Supreme Court said no, states can't be forced to do that. And then 2 years later, this question came up just last year. Does the ACA permit the federal government to subsidize premiums on the federal exchange, on the federal marketplace that was put together? And here the court ruled 6-3, yes, the feds could do that. So, what's the alternative to this mandate model? It's what we like to call improved Medicare for all, or a single payer model. The idea would be to actually build on the original Medicare program, expand it to the entire population, and one could conceive of different ways of doing this. You could start with children, and then expand this. You could decide to, in fact, do it for everybody in the population. Improve coverage so that it includes preventive services, dental care. One of the fascinating things about Medicare is that it doesn't cover dental care, and it actually doesn't cover really long-term care. Eliminate deductibles and copays, because the Medicare program actually has now a pretty significant deductible in it. And that really restricts access, as we'll talk about in a few minutes. Expand drug coverage, because the drug coverage in the Medicare program is all given through private health insurance companies. Medicare itself does not sell drug coverage. And phase out the Medicare Advantage program, which is a program that a beneficiary can designate a private insurance company to manage their benefit. It's really an attempt to privatize the single-payer part of Medicare. So that's what we're going to contrast, is these two programs. And we're going to look at them in terms of the challenges that facing our system. Declining access, escalating costs, a lack of comprehensive benefits, restricted choice, uneven quality, insufficient primary care, and then we do have the problem if we're expanding health insurance, how do you pay for it? So let's start with declining access, and just to give you a sense, since 1976, roughly 1 million more uninsured people in the United States. Pretty remarkable, right? A little dip here in the middle of the 1980s when the Medicaid program was actually expanded. A little dip at the end of the 1990s when the Child Health Insurance Program was created. And then another dip here in 2011-12 when kids could keep on their parents' policies up to age 26. But otherwise, a remarkable problem with increasing uninsurance in the United States. So how does the ACA deal with the issue of lack of access to care? Well, it says you gotta have health insurance. That's the mandate, right? And it went ahead and expanded Medicaid eligibility up to 138% of the poverty level. And just to give you an idea of what that is, it would be an income for a single person of roughly $16,000, and for a family of 3, $27,000. Okay, but a lot of states, opted not to expand. Initially, 24 of them. Some have now decided to expand, so it's down to about 20, as you will see later. Then it subsidizes premiums up to 400% of the poverty level, and here the incomes are more substantial. And the problem is that the ACA never specified how large that subsidy was going to be, so we don't know exactly how big it is, but we can see what's in the plans as they have rolled out. And finally, there are the market reforms, age up to 26, so no pre-existing condition exclusions, no annual or lifetime limits. One of the great pre-existing condition exclusion that was there is that many private insurance companies, you'd go to a new job and there was a 9-month exclusion. You would not be covered by health insurance for 9 months. Why is that? What is the thing that happens in 9 months? Pregnancy, absolutely. So they were trying to prevent people who didn't have insurance from getting insurance just to cover the pregnancy. No longer something they could do. So what did this do in terms of the number of uninsured? Well, it actually did decrease them, as you can see here. And we are really at the end of 2015, the beginning of 2016, pretty much at this estimate that was made by the Congressional Budget Office of roughly now 30 million instead of 50 million uninsured in the United States. But the major thing to realize is that the ACA is not a universal coverage program. Well, how would a Medicare for All deal with the problem of access to care? The important thing to look into legislation language is, is there automatic enrollment? You present to the emergency room of a hospital, they do their wallet biopsy on you, and they find out you don't have health insurance. What an opportunity! Let's sign you up to the National Health Insurance Program. You deserve to have health insurance. The hospital will love that. Your doctors will love it, right? Is there any private insurance company that would sign you up in the emergency room of a hospital? No way. So that's what's really different. It should be a federal guarantee. And probably the most controversial thing I'll say tonight is that I think it ought to, in fact, include all residents of the United States. Oh, you mean people who are undocumented? Yes, I live in New York City. I think that's really important, okay? Yes, we might have some restrictions that someone would have to prove residency of 1 year or a year and a half, so people wouldn't just come to the United States to get free health insurance. But the mantra should be everybody in, nobody out. All right, well, what about costs? That's the other big issue that people were concerned about in passing the ACA. And indeed, there is a problem, right? If you look from 1999 up to 2012, premiums had gone up, 172%, right? And the workers' contribution to premiums had actually gone up higher than that, 180%, when workers' salaries only went up essentially 47%, and inflation ate away 38% of those. Little wonder that one of the most common reasons that a union would go on strike in this period was the fact that the employer was trying to shift more costs for health insurance onto the employee. And indeed, it's pretty expensive. Do you realize that for each of you in this room, $6,251 is what, in fact, you would have to contribute if you got individual health insurance. And, if you were getting family coverage, it's up to $17,545. That's the national average cost for a premium, depending on whether you're an individual or in family. And you can see what the employee has to contribute to that. For a family, close to $5,000. So how does the ACA deal with this kind of cost problem? There really is one. And the theory is, you know, a market theory. Let's mandate that young, healthy, uninsured people have to buy health insurance, right? That's what we need to do, because they usually don't get sick, they don't get health insurance frequently. Young people didn't in the old days. And since they were low risks, then it's possible that, you know, their cost of health insurance in terms of what they would use in healthcare would be lower, and therefore an insurance company could reduce premiums. That makes sense? Well, okay. But I just told you what it costs, right, in premiums, and I told you what the, in fact, penalties are. Well, you know, I'm not sure these penalties are sufficient to really, in fact, get people to pay this kind of money for private health insurance. And indeed, that, I think, has been the case as we look at the history of how the ACA has rolled out. And indeed, this from the New York Times just about 6 months ago, the estimates on health insurance increases, I was really astounded by this, you know, 54% premium increase in Minnesota is what was projected. Now, they haven't allowed that to happen. The health insurance regulators in Minnesota have not let that happen, but that's what they were asking for in that state. And the ACA, in terms of costs, has, I think, some very interesting imaginative techniques for controlling costs over the long term, but they're unproven. One of them was health information technology. Let's get every doctor to have a computer in their office. Let's have every hospital computerized. And at the outset of the ACA, that wasn't true. About 60% of doctors had computers in their offices, and many small community hospitals weren't really fully computerized. So it seems to me that it would probably cost a lot to get yourself onto a computer. And so there would be initial startup costs that would be substantial. This idea of chronic disease management, a wonderful idea that Ed Wagner came up with out there on the West Coast, but never really submitted to a randomized trial to prove that it's going to save costs. And then there are these things called ACOs, bundle payments, value-based purchasing. You're going to hear a lot more about these over the next few decades, but even more immediately, really, over the next, I'd say, 5 years. And so far, I don't think, I mean, the jury is out, but it's not clear that these are going to save a lot of money overall in the system. And indeed, you know, when the Congressional Budget Office or the CMS actuary or the Commonwealth Fund, a group that's very pro-ACA, made estimates about healthcare costs, you can see that by 2019 they estimate that we'll be close to $4.6 trillion in healthcare costs in this country, and that we're likely to get up to somewhere around 20% of gross domestic product. Now, it is true that for the last few years, there's been a little bit of a leveling, and so we are still, at this time, somewhere around 17 to 18%, right in this area. We're not up to 19% yet. Well, so I would argue the ACA isn't really going to control costs. Well, what would a Medicare for All do? Okay. Well, the major mechanism here for controlling costs is the notion of a single payer, reducing the administrative cost and profit that private health insurance has inherently built into it. And when you look at the Medicare program, its administrative cost is somewhere between 2 to 3% compared to private health insurance having a 16 to 30% costs. And in this article in the BMC Health Services Research Journal, it is estimated that $375 billion could be saved if we converted from our for-profit private health insurance to a Medicare for all or single-payer system. Well, how does that happen, really? Okay. Well, here's an estimate that comes from some work that Gerald Friedman, the head of the chair of the economics department at UMass made for New York. And indeed, what happens is that it will cost more to cover the uninsured or the poorly insured. It will cost more to eliminate co-pays and deductibles, which a single payer would try to do. He proposed that since private health insurance tends to pay a little bit more than Medicare and Medicaid to hospitals and to doctors, let's raise those rates up to the private insurance level, and that's going to cost more, substantially, as you can see. So that there's a total additional cost by going to single payer of 9.1%, but there are these enormous savings. And what they involve are reduced physician and hospital administrative costs. You would be able to hire fewer people dealing with billing and collections. Less people in my office, for instance, having to deal with prior approvals of medications and procedures and so on. I just spent, yesterday, frankly, more than an hour on a telephone call, with a pharmaceutical company trying to get a prior approval for a patient of mine. There would be reduced insurance administrative costs because the insurance companies all hire advertisers, number one, right? Number two, have people who are there to deny claims, essentially, to do prior approvals, to try, in fact, to enhance their ability to make money. Then we would be able to do bulk purchasing of drugs and devices. What entity in this country gets the lowest price for medications? Anyone have an idea?
The VA.
The VA, right. Why? Because the VA can negotiate directly with the pharmaceutical industry for price. Medicare can't do that now because Medicare has to go through private insurance companies. In my state, we have 30 different private insurers who offer the Part D Medicare benefit. Well, we could save an enormous amount. There would be reduced fraud. There would be a total savings of somewhere close to 25%. And the net then could be somewhere around 10 to 15%. We could really see a decrease in the costs of healthcare for the population. And this illustrates that a little bit more dramatically. This is the number of physicians and how they've increased over the past few decades. And look at what's happened to the number of administrators. We need to amputate that group. Give them meaningful work, instead of denying claims and, pushing papers. The bureaucracy has to go down, right? We could deal with some of these salaries, right, of the private insurance companies. Look at this, United Healthcare, $66 million in 1 year. Wow. Cigna, $27 million. It's just WellPoint, $8 million. This is just ridiculous, it seems to me. And here, from a conservative economist, Carl Schramm, an estimate of what happens when, a nonprofit blue becomes an investor blue. But what I like about this slide is that he kind of agrees about the administrative costs of Medicare, 3%, 3.1. But this is what convinced me he is really conservative. He wouldn't say 20% is the overhead, 19.1%. 99.9% for commercial insurance. And, you know, there isn't just a one-time saving by going to single payer. You could imagine and think of other techniques that can be used. The global budgeting of hospitals, which interestingly is being tried right now in the state of Maryland. A lot more capital investment planning so that you don't have MRIs that are not being used, efficiently. A greater emphasis on primary care, alternative ways of paying for care, and yes, the bulk purchasing of pharmaceuticals. So I think a single payer approach does deal with the cost issues in the healthcare system. And that's really one of its most persuasive qualities. Well, what about the comprehensiveness of benefits, okay? Here one should not just think about the services that are covered, although I think they're important. Again, having dental, home care, nursing home care, but very important to be sure you look at how comprehensive is the financial coverage, the copays and the deductibles. And here what you see is that from 2006 up to 2015, in terms of the average employer-based insurance, private insurance, the deductible has gone up to over $1,000. So this is, again, a real problem. And so I think there's a real epidemic of underinsurance. And my definition here is pretty simple. The number of people who spend more than 10% of their income on healthcare, if you do that, you are underinsured. Okay, and back in 2000, it was roughly 42 million. It had gone up to about 62 or 63 million in 2007, and it's estimated that it's close to 80 million now. And what you can see is that these are people not just who have no insurance, but people who have health insurance, but the deductibles and the co-payments and so on are just too high. Little wonder that 62% of personal bankruptcies in the United States are due to medical expenditures, and over 75% of those people had health insurance at the outset of their bankrupting illness. So, really a major problem. So how does the ACA deal with this? Yes?
That was 2009 data on the personal bankruptcies. Would the annual and lifetime, is there an annual out-of-pocket limit and a lifetime out-of-pocket limit on personal out-of-pocket spending, and has that affected the personal bankruptcies from healthcare at all?
I have not seen a study that has dealt with that, so I can't tell you the answer to that per se.
Because that would not reflect post-ACA.
You're right. The bankruptcy data is stuff that Elizabeth Warren actually did before she went to the Senate, and it doesn't quite reflect. But there is a very interesting study that just came out from, I believe it's Kaiser and Commonwealth, asking people about, did they have problem with medical bills? And it's remarkable how prevalent that is, not just for people who have no insurance, but for people with insurance.
A lot of high deductible health plans.
Pardon?
A lot of high deductible health plans.
That's right. Exactly. And that's what I think the ACA has stimulated the proliferation of, frankly. So how does the ACA deal with comprehensiveness of benefits? There is an essential health benefit package, but it's not truly a standard practice benefit package in terms of giving you the amounts of copays and deductibles and so forth. It's only preventive services under the ACA that come out without copays and deductibles. And it stipulates that health insurers must have a medical loss ratio of 80 to 85%. Many of you heard of the medical loss ratio. This is a fascinating concept, right? From the perspective of a private for-profit health insurance company, any dollar spent on a hospital, on a medication, on a doctor, is considered a loss, right? And only then what is left over for profit is in fact something that can go to the shareholders, the investors in the company. And this concept, the medical loss ratio, is one the insurance industry had, but I've noticed they've really downplayed it because they realize this doesn't sound good. What is health insurance for? But in fact, to allow you to use health care. And then there's no regulation on the magnitude of premiums and deductibles and copays, just the stipulation that benefits have an actuarial value of 60% or higher. What is actuarial value? Well, here's a great slide from the insurance industry, from Wellmark. And it conforms to the whole metal classes of things, right? So if you have a bronze healthcare plan, the insurance company pays 60%, but you pay 40%. If you have a silver plan, the insurance company pays roughly 70%, but you pay 30%. A gold plan, 80-20, and a platinum plan, 90-10. The average employer plan has had an actuarial value of around 87 to 88%. This gives you a framework in which to think about this. And if you look here in New York State, just to give you a sense of the cheapest bronze plan in the state, had a family cost of, premium cost of $10,500. So it was less than what the employer plan was. Remember that $17,000. But it has a $6,000 deductible and a 50% co-insurance after the deductible on all of these services, with an out-of-pocket maximum. You mentioned that earlier. That's in the law, of $12,700. It's not clear to me, again, that the ACA gives us truly comprehensive benefits. What would a Medicare for All do? We would want to see that be very comprehensive in terms of the list of services covered. All medically necessary services. Would there be any exclusions? Well, probably yes. Tummy tucks, Botox for wrinkles, I think I'd exclude them. Maybe even private rooms in a hospital, unless medically necessary. So I'm in a room with you, the resident comes in, you're coughing away, and he says, oh, I think you might have tuberculosis. Get me out of his room, right? He's got a medically necessary reason to have a private room, okay? That should be covered. How should these things be decided? Yes, I think there should be a coverage board of some kind that includes doctors, hospital representatives, but also patient representatives, so that one, in fact, can make decisions about what is covered by the National Health Insurance Plan. And an improved Medicare for All, I would argue, should, frankly, get rid of copays and deductibles entirely, okay? I think that they're a way of shifting the cost of health care from the insurer onto the patient. Frankly, it treats health care as a commodity rather than a right, and it assumes that patients are shoppers. And yes, they do go around and shop, but there are some ways in which you can't shop in medicine. You're having a heart attack. The doctor says, I think what you ought to do is, have a bypass surgery, are you gonna go out and shop for the bypass surgery? Come on, it doesn't happen. For the very expensive things, you can't shop. And it postpones needed care, and because it does that, copays and deductibles increase costs. Healthcare, I think, should be free at the point of delivery. Well, what about choice? Okay, 42% of employees in the United States have no choice. Why is that? Anybody have a guess? Their employer offers how many plans? One. That's not choice, right? And in fact, private health insurance limits your choice to a network of doctors and hospitals with whom they've negotiated contracts. And you have to pay more if you go out of that network, okay? And sometimes substantially more. And what you see here, for instance, is silver plans restrict the patient's choice in this approach. And you can see, that when you look at all specialists, you can have some very, very narrow networks, the ultra narrow or narrow ones, and only really about 1/5 of the doctors, 20%, are, willing to, in fact, take you. But when you get to really some of the specialists, like the oncologists, what you find is that, a very few of them are in a broad network. So how does the ACA deal with this? Well, it's essentially this idea of creating the health insurance exchange, the marketplace of health plans. And I think, yes, that does increase choice for some. Enrollment is usually limited to those in the individual and small group market. The exchange is fundamentally a private health insurance marketplace, but there's no public option. There are only 17 state-based exchanges. 33 states are essentially using the federally facilitated marketplace. And the law, actually the ACA, stated that no single-payer plan is allowed until 2017. Okay. Well, how does a Medicare for All deal with this problem of choice? Well, there should be no limit to a network of private providers. There should be free choice of doctor and hospital. We would finally join the rest of the industrialized world and de-link our health insurance from employment. It would expand choice for everyone. And this limitation on state single payer, well, don't tell that to people in New York. We've created a bill, the New York Health Act, which is a single-payer state bill. This is the head of our health committee, Dick Godfrey. This is one of my medical students from Cornell. I understand that there's even a state bill here that's been proposed. But the amazing thing is that we got this voted on May 27th, 2015. And 92 assembly members voted in favor, 52 against. We really had a substantial majority that favored a very strong single-payer bill. Yes?
Thinking about networks, a lot of the reasoning is that we want to choose physicians in our network with high quality and high cost, or high quality, low cost, but what nobody knows how to measure quality, so it becomes cost excluding certain providers from the network. When you expand the network to include all providers, you would in theory exclude some physicians from practicing because we have.
Well, you see, my sense is you're talking about a network that one could conceive of there being a network in a single-payer approach. That's true. But, one doesn't necessarily have to have a network. Physicians would be able to get compensated, without joining a network. So I don't think it's inherently necessary for them to be in a network. Anyhow, state single-payer approaches are interesting, controversial. Our problem in the state of New York is that we have a Republican-controlled Senate at this point, so our task to get something passed there is going to be still quite formidable. And then, of course, we have a governor to deal with as well. But state single-payer is something that, as we get closer to 2017, is going to be really looked at. And I just thought this was an interesting slide. It shows this color are the states that have expanded Medicaid, and I noticed that you have done that. Actually, I looked it up. You've had actually a 43% increase in the number of people on Medicaid in the state of Rhode Island. That's impressive. But what I really wanted to show you is, are there single-payer initiatives in states? And those that have these lines here, say like New York, Pennsylvania, Colorado, California, those are the ones where there are things at least stirring within the state. Are they close to getting passed? Maybe they're like New York, not really. But a lot of activity in this area of state single-payer, and you should know more about it here in this state. What about quality? The fifth problem that we have to deal with, in 2014, the U.S. was the last among 11 industrialized nations in health system performance, according to the Commonwealth Fund. Okay, and we had fallen backwards because we were fifth in 2004. So how does the ACA deal with quality? Comparative effectiveness research, very interesting. An innovation center in CMS. Value-based purchasing, again, not proven to really work. But readmission penalties, people who are readmitted within 30 days because hospitals may be trying to force them out too early, and reduced hospital payments for acquired conditions. So some very practical ideas. But will they really improve quality in the system? What I'd like to see is a Medicare for All would give us a national database. Right now our problem is that private insurers keep their data proprietary. They clearly don't want to be shown to be funding poor quality care. But if we had a Medicare for All, that's why, by the way, most studies on quality that you see are Medicare studies, because that's the only available database. We could have some national standards, and finally, I'd really like to see everybody being able to get, their data on a little credit card-like thing, which would have your EKG, your blood pressure, your medications, your last CT scan or what have you, and that would be available that you could bring, to the emergency room, to your doctor's office, what have you. This is the approach, frankly, in Taiwan. I was there 2 years ago, and people loved to show me this card. They just went around and said, hey, look, I've got my data right here. So finally, insufficient primary care. You're all aware of this problem. 84% of graduates have educational debt. The average debt, wow, $176,000. Primary care is under-reimbursed, so little wonder that more and more graduates are going into the specialties. How does the ACA deal with this? Yes, there is a primary care bonus payment, but it's going to stop after this year, interestingly. And it was pretty small, not enough to induce you to go into primary care. Increased Medicaid payment to the Medicare rates, but it's going to end this year. And then this thing called the Independent Payment Advisory Board, which actually has not been implemented. How does a Medicare for All deal with this problem of the lack of primary care, I would argue we should go toward free tuition. Yes, and then you might have some payback after you graduated from medical school. But there should be debt forgiveness for people who go into primary care, and that can happen now. It does happen in federally qualified health centers. If you spend 5 years in an FQHC, you will get some debt forgiveness, you'll get malpractice payment. We'd really get to where we could have patient-centered medical homes. And finally, how do you pay for all this reform? The ACA pays for it in some very controversial ways. One of them, and you're going to hear a lot more about this, is the 40% excise tax that's going to be placed on health insurance premiums and plans that are more comprehensive, particularly the employer-based plans. They want more cost sharing to take place on the part of enrollees. There is a Medicare payroll tax increase for those with very high incomes, and there even is a tax on investment income, which a lot of people don't know about, but is pretty impressive, I think. And then all these calculated savings from Medicare, again, not clear that those will be easily realized without compromising the program. And then everybody talks about fraud and abuse. How does an improved Medicare for all deal with how it raises money to pay for things? Is by going to a graduated payroll tax. In essence, what we would do is take the employer contribution now to health insurance premiums. We'd be able to reduce it a little bit, but in fact try to scale it to the income that a patient has or that an employee has. We can use corporate and income taxes, and then also this kind of tax on unearned income. By and large, I would argue we should go away from premiums because they're fundamentally regressive. The president of the company pays the same premium as the secretary, and yet their salaries are so different, right? Now, there's been a recent argument that we really should use the word premium, interestingly, in P&HP. We've been kind of talking about it. What we're talking about is a premium that is scaled to income, not a single amount. So, and there would be no increase overall healthcare spending because of the administrative savings. I'd like to be sure that you know that this is not socialized medicine. Why is that? Because doctors are not salaried by government. Hospitals would not be owned by government. That's really what socialized medicine is in the UK, in Sweden, in Denmark. No, this is, essentially publicly funded but privately delivered healthcare, okay? And we have it in the Medicare program. That's the way Medicare presently operates. So, truly in summary, with the Affordable Care Act, what do we get? Expanded coverage, but not universal. Cost control by market means, no definition of benefits, risk of increasing underinsurance, choice through state-based exchanges, but no public option, primary care and ACO pilots, and funding using an excise tax on private health insurance and Medicare cutbacks. What do you get with a single payer program? And you can go to our national website and actually get more information about this. But universal coverage because of automatic enrollment, low administrative costs because it's a single payer, comprehensive benefits without copays and deductibles, maximum choice of doctor, nurse practitioner, or hospital, improved quality through nationwide HIT, expanded primary care, publicly funded and privately delivered. The Cornell medical students say, I should call this Medicare 2.0. And we have bills in Congress put forward by Representative Conyers and one by Bernie Sanders in the Senate. And, you know, when you look at it, it's kind of fascinating. Here's a poll that was taken now a year ago by the New York Times and CBS. Would you favor or oppose government-administered health insurance, something like the Medicare coverage that people over 65 and older get, that would compete with private health insurance plans? Okay, it's not a single payer. Well, 59% of people favor that, 34% oppose it, but they have no opinion. But then they ask the question more directly, would you favor or oppose a single-payer healthcare system in which all Americans would get their health insurance from one government plan that is financed by that horrible word, tax? And what you see is 43% favor that, 50% oppose it, oh, but 7 have no opinion. We just have to persuade those 7 to come over here. And we would at least have 50-50, okay? So, in summary, I believe that a system based on private insurance plans that are not going to lead to universal coverage will not create affordable insurance, but a Medicare for All system can lead to universal comprehensive coverage without costing more and has the greatest potential to increase choice, quality, and primary care, and can be financed fairly. What if we don't do this? Here's an estimate of the amount that household income is going to go up. Here's, based on optimistic ACA assumptions, what's going to happen to the cost of healthcare, such that by 2038, an entire household income will be spent on healthcare, a condition not compatible with life. So, at the end of a talk like this, people always ask me, well, what do I think? Is the ACA a step forward or a step backward? I kind of understand those people who think it's a step forward because it expands coverage through Medicaid and private insurance, and it has helped perhaps 30 million people, or 20 million, pardon me, going from 50 down to 30 million. But I also think it has the potential for being a step backwards because it gives our taxpayer money to private insurers. So my conclusion, frankly, is that the ACA is a great leap sideways. And you guys are going to be living with this issue because I think we have to go beyond the ACA to a single-payer system. And I love this optimistic statement by Martin Luther King. He said, "The arc of the moral universe is long, but it bends toward justice." I would say the arc of history is long, but it bends toward access to health care for all. And here are a few resources that you can look up. I hope that you really consider taking the free offer of becoming a member of PNHB. You can get some really interesting information through that process. It'll allow you to get on to, a thing called Quote of the Day, which doesn't come every day, but comes about once a week. A great analysis of what's happening in healthcare reform and healthcare delivery system change. So, I've probably taken way too much time. What time is it? There's no clock in this room. Well, about an hour. Any comments, questions, debates? Yeah.
So thank you so much for coming. I thought it was really interesting what you said about the huge difference in administrative costs between Medicare and the private insurance. And I was wondering how much of that that's because 2 to 3% is ideal for how much administration they have to do. It seems hard to believe that 2 to 3% of their budget going towards administration is enough. Do you know what I mean? Like, is that because that's all the money they have for it, or is that because they've become so streamlined that like they can do it on 2 to 3%?
Yeah, it's a good question. My sense is that you may be right that, if we got everybody into the system, we would end up with a little bit higher administrative cost, but I think that, fundamentally, we can get away with a lot less bureaucracy in the healthcare system. And that's really what I think Medicare for All can do for us. How much exactly? Well, we rely a little bit on the healthcare economists to give us some insight into that. Yeah. Yes?
I think one of the main initial criticisms people have is, this is all well and good, try getting it passed. I would like to say, let's assume that it's passed, much like the ACA. Since something like the ACA has been passed, it's been existentially threatened every which way to this day. To what extent do you think, if a Medicare for All was passed, would it be existentially threatened politically every which way?
Well, I think that was precisely the projection when the Medicare program was passed. There was quite a bit of opposition to it from the AMA and so on. But once it's been there, you're not going to be able to take it away. I think if we had a Medicare for All, it would be very hard to politically take it away. So, going back to your original statement, is this feasible? Okay. Politically, one could argue, looking at the political landscape, it sure doesn't look like it, does it? But amazing things happen politically, right? I mean, if you were in this country in 1859 and someone told you that slavery would be abolished in 2 or 3 years, would you have believed them?
Took a Civil War to get there.
True. But slavery was so crucial to our economy in this country, I think you wouldn't have believed it could happen. But it did, okay? And it seems to me what's important for physicians at this time is to have that vision and to articulate that vision. People really respect us about the healthcare system, and they will, I think, see this as a really important reform to see happen. And I think amazing things happen. And this is one of them that is actually potentially, can in fact be accomplished. So even though it appears politically unfeasible, it's really important to advocate for it today. Other questions? Comments?
We can imagine a system this expansive being based. Would it be based at CMS? Would it be Medicare 2.0? Would it be something completely separate, where they start over from scratch and build it?
No, I don't think one would want to start over from scratch. So I do think it would probably be, an entity like, our federal CMS program expanded to the rest of the population. CMS contracts. It's the other side of this that's interesting. They do contract with private insurers to do some of the spade work here, the simple work. Billing, collection, and so on and so forth. It's just that it doesn't have to do all the other things, the advertising, the challenging of, the prior approvals and all of that. I mean, it just, because if you're a private insurance company and you're trying to make money for your investors, you have to compete with the other private insurance company that's doing the same thing. And so you just, if they're denying claims, if they're asking for more prior approvals, you have to do it, as a private insurer, otherwise you'll go out of business. So it's that we can get rid of, it seems to me, by moving to a single payer. Anything more? Okay, great. Well, there is a little sheet here. Why don't you give us at least your email address? And just so that we can send you one email. I should have passed this out earlier. And then if you want, there are some brochures and things to look up. Did you have a...
Oh, no, just
Pardon?
Well, it struck me, I mean, as far as the amount of money that's being wasted here, I mean, the thing that happened in California recently was a really good example where the state legislature did an audit of California Blue Cross and found that this not-for-profit entity was sitting on $10 billion in cash reserves, at which point they promptly deprived them of their not-for-profit status. And it's one state, and that's a lot of money.
Mm-hmm. Mm-hmm. Yeah, no, I mean, that's, the health insurance industry is a big industry, no question about it. And it's, when you're talking about a proportion of the economy that is somewhere around 17 to 18% of the total economy, you are talking about a big chunk of money, no question about that. Another reason that it may be hard to make the change, but that's why I think the slavery example is so interestingly important. Slavery was absolutely crucial to this country's economy in the old days. And you're right, it took a civil war. I'm not sure we need to get into that this time around. But this is both feasible and, even if it appears to be unfeasible, important for us to be advocates for as doctors. Yes?
In your presentation, as part of your solution, you said phase out Medicare Advantage, which I can understand because that's, Medicare providing financing to commercial insurers to give a public benefit. But 30%, roughly 30% of all Medicare beneficiaries choose Medicare Advantage because they offer services not covered by traditional Medicare. I'd imagine traditional Medicare would like to offer a lot of the services that Medicare Advantage provides, but due to political fallout, gridlock, whatever, it doesn't. To what extent do you think a Medicare for all type of program without Medicare Advantage would be able to provide, break through whatever political gridlock to get the additional services Medicare Advantage today provides?
Yeah, do you have a sense of what those additional services are?
Transportation services if you can't get to your office visit. Another example would be, how long has it taken for Medicare to get the end-of-life discussion as a reimbursable benefit? Only now is it actually reimbursable, but every time you try to add a benefit onto traditional Medicare, it is a huge and long process. Whereas with Medicare Advantage, for better or worse, a commercial insurer can do what it wants. So to what extent do you think that would or would not be a problem in expanding benefits under Medicare for all, as opposed to Medicare Advantage type model?
Well, what happens under Medicare Advantage is, number one, it's costing the Medicare program 14 to 15% more than if those patients stayed in the traditional Medicare program. So, in a very peculiar way, what's happened is that this may save some money for the individual beneficiary, because I think the real benefit of Medicare Advantage is that they sometimes actually reduce the deductible and the co-payments, and even the premiums for Part B of Medicare. There's a premium component there, so that the Advantage programs actually have a major financial advantage for patients, and that's why I think is the real reason they enroll in them. But it costs the program, a great deal more. My sense would be if we eliminated copays and deductibles, yes, it's going to cost Medicare more, but that's what we really ought to be doing. And therefore, I think it should be possible to do it, yeah.
Thank you very much, Dr. Fine. And please feel free to stay and interact individually with Dr. Fine, but I think it's probably time to wrap it up.
Okay,
So thank you very much all for
thank
coming.
you.